So we're mid-conversation with a famous Doug Hetherington, who's one of my favorite folks to talk to because he's brilliant. That's why you have no hair, Doug. All that brilliance needs to be harnessed by your brain. No, seriously, the topic we were talking about earlier led me to this question about how, and you were talking about how, we think we equate the network with security, but we realize when the consumer realizes, I don't have the network, but I still have access. So why did I rely on that before? So here's my question is that, if consumers truly, they drive every industry, why is that different in healthcare? Why don't they drive in healthcare?
Yeah. If you think about it, right, I don't know if there's ever anywhere else in our lives where we engage in consumerism, where we have to go buy a product from one party in order to actually get the service then from a third party that we could have actually just gone and bought it from direct in the first place, right? The reality is you don't need an insurance plan or a network to go see your doctor. You could walk in with cash and pay it. So somehow, some way along the way, right, and probably going clear back to the 40s, we've almost conditioned ourselves that we need this insurance system, that it's what we're based around. And maybe it's also because even the way that it's kind of purchased, where it's employers doing it, the purchasing with the insurance company to then represent the services of the provider on behalf of their workforce and their families. Right. I mean, think about all of these people we have intertwined into it.
Coming out of our checks sometimes. So.
Right. Exactly. So by the time this actually hits that employee, even on their paycheck, it's been a dictation. There was no consumerism whatsoever. So now they're really engaged in a model where they're going, well, okay, keep telling me what to do. That's in essence how most people, I think, begin to look at it. And I think along the way, that's where I looked at it and said, wait a minute, we do this because it's just been a behavior that we've been taught. And so that's kind of where we often base kind of around our model, is to say, if we have to break that mold, you have to bring that member into part of the process to say, here's how the decisions were made. The decisions were made this way, and here's why. So that, like when an employer will work direct with a health system, or even an independent person is working direct with a physician, there's really value given back and forth now. There's some meaningfulness to it. It's not just, here's the panel of doctors you go to in your copay. It's, hey, we are working with this subset of, risk managers, providers, healthcare workers in our community, and they're going to work more directly with you. And here's the benefit: a better relationship, lower costs, and we're really going to encourage that you go, but we really would like you to choose to go here. We'll let you go anywhere, but this has some preference, and there's going to be some definite carrots to it. Well, wait a minute. We just engaged a level of consumerism, right? We really put nuggets out there. I think today, unfortunately, most people see it that I don't really even want to pay the bill to go to the doctor, let alone if I have a deductible and all of that. It's probably bankruptcy. And I think that's where we've got to change the value proposition, that truly when the consumer makes a better decision, they feel that in a positive way immediately in their pocketbook. So that's where really everybody's buying back into it. But what's awesome about that is that now when you've got that person re-engaging and feeling as if they've got value in it, imagine what happens once they actually walk in the door with the provider. We've removed all of the kind of the financial barriers and cobwebs. They also know that their employer is saying, go have a relationship. So there's almost this sense that I'm being told to utilize this investment. It's not just that I'm buying something that I begrudge now. I'm actually now engaged in this because my employer says this is how we're going to solve the problem long term. And as a patient, this is what I've been wanting all along anyway. And the provider on the other side is looking at it and saying, all the restrictions have been moved, the insurance company barriers and directives and everything that we have to go through, all the hoops, gone. I can now just have a relationship with my patient. It's like a reset of every stakeholder in that equation, right? Yes. But when all of a sudden, then you get this annual financial stability between the health system and the employer, the value proposition then stays the same. So we continue to encourage, continue to go, and we don't have to hit them with detractions in the plan design over time. So we just continue to reinstill then year in and year out this is the model and this is the relationship we're going to engage in, and you get a completely different result than what you see in the market today. So to us, that is a better way, even though you've still got all of the same stakeholders, sans the insurance company. You've now put incentives in place and in essence, a reason for everybody to engage.
And then you really can invest in the wellness from the member's side, from the member's perspective. You really get to go see. Well, I know I talk to people all over the country. They can't afford to go to the doctor. All they can afford is and how hard is that on a provider, right? Because they know they're not going to see this member except for that free wellness visit, right? Yeah. And so they're missing really important pieces to, when you talk about long-term kind of visionary things, catching things early like cancers or kidney disease, my favorite, right? Or those kinds of issues. Mm-hmm. And then the physician can really practice versus being told, hoops he's got to jump through to take care of his patient.
Yeah. Well, so, and that's the thing, right? I think we've all been pushed out to where there's no value in the system and how it's structured today. It's like, what's the point in even engaging as a consumer? One, if I'm, the patient or that employee, it's not really my dollars up front. I don't have the ability to redirect them somewhere else just with the flip of a switch, right? I get one time per year. I got to make decisions for myself, that if I've got family members that, have coverage elsewhere, now I got to compare all of that. We're just adding more complexity to it. So I think I can see why it's really easy for people to just disengage and candidly be horrible consumers of healthcare. And sometimes I wonder if that's by design, because it seems that it continues to move this direction kind of, as long as we stay in kind of this just traditional mode of defaulting to insurance carriers and networks, and to where there really isn't a relationship directly between the patient and the provider per se. So we do believe that those are kind of fundamentals that need to be reinstilled into that transaction in order for there to truly be some level of consumerism available in healthcare. But I do believe that once you layer that back in, you're really starting to now layer the building blocks of a new foundation of how we engage in healthcare, because then it becomes more about not just the cost or how far is this provider versus another, but maybe there's actually something about value, quality, outcomes, right. And to where people aren't just saying, hey, this is my doctor. It's rather they say, this is my health system. Right? Where I'm actually going to go say, I'm going to choose, health system A versus B and C, because they have this and this, and for whatever reason, that's meaningful to me. And I think that that's different now, right? Because now that's a different approach of how we're even looking at ourselves from a healthcare standpoint. We're not looking at it as one incident or engagement at a time, but rather we're taking our body as a whole into consideration and recognizing this is a lifetime investment and relationship. So I think that there's so many things that we can build on once we start to reverse kind of this apathetic attitude towards healthcare, as we can kind of start to reinstill some confidence in getting people feel as if they are getting value back out of it. I think it's going to be fantastic what we see then come from it.
Oh, that space is pregnant with possibility. But
absolutely.
But then too, kind of like what you and I were talking about earlier, and where we were talking about how a lot of folks, as you talk to folks all throughout the country, what is DPC, what is direct contracting, and so a lot of folks that I'm talking to, they're embracing direct contracting. They love the idea of having that relationship with a doc who's going to practice for them versus, practicing for the insurance company, so to speak. But they already have health insurance, right? So it kind of like what we were talking about earlier. It's not this either or kind of situation, but how would you, talk about that?
Yeah, it's almost like we're basically saying the traditional model as it exists today has almost no level of consumerism, and then the predominant kind of DPC model as it's being presented out there is almost based 100% on consumerism for both the provider and the patient, to where they're circumventing the insurance company, but really they're circumventing insurance altogether. right? And so I think we have to remember that we're talking about one aspect of healthcare. And I think that that's the part for us that we look at and say, that's where the big but comes in. Because you're right, for like 99.9% of the time, we can say we might be able to actually have a better engagement through some form of direct primary care. But the problem is, it's when we get that one huge claim, right? It's that massive claim that really impacts people. And that's what causes them, or an entire health plan, to blow up. It's where you see those 30% increases that we've heard so much about over the decades.
Yeah.
And so, I think that we first have to get our arms wrapped around the financial drivers of healthcare. And really, it is those catastrophic losses. And I think if we can start to address that, then you can begin to look at the engagement side, the preventive side of healthcare, and say, okay, how do we better address this? Well, let's face it, DPC is a very much a frontline, family practice, personal care, day-to-day practitioner, versus catastrophic claims are usually happening in your hospitals. And these two aren't necessarily, they're symbiotic in nature for the whole spectrum of healthcare, but the value proposition between the two couldn't be more opposite. Right. And yet I think what we've got to recognize is that most hospitals know they need the frontline primary physicians to diagnose and treat, work with patients, and ultimately identify, hey, we have a treatment that now requires the hospital's input, or unfortunately, we've had a huge accident. Whatever that might be, we have to figure out a way for them to work better together. And candidly, I think that when you look at large health systems, they have a desire to be more meaningful to their patients. And I know their providers do. And so
communities.
Absolutely. So it's almost important to say, okay, how do we teach a health system to convert the way they offer their services? Again, it's so predominantly based on an insurance model of fee for service. But I think most people would say, hey, I just want the insurance for the catastrophic stuff. I'll pay a couple $100 a month for my policy, even give me a deductible, that's fine. But I just want to go see my doctor. I want to have a good relationship. Even if it's a $10 copay, no big deal. But when all of a sudden it's HSAs and I'm being expected to front all of these expenses, people aren't going to go, right? You don't know what the costs are up front. So that's what I love about the DPC model. If you can figure out how to bring that into a holistic manner, you've now developed something where I think it's more like your car, right? We all recognize.
I was just thinking about that too.
Yeah, we've got to take care of the day-to-day stuff, right? It's like, I don't expect my insurance to pay for my gas or even my oil changes, my tires, all of that, right? That's wear and tear. That's on me. But at the same time, when the big thing happens, because it's just going to happen, all right, that's when I need the protection. That's when I need the help. And I think we've confused the two so much, but it does. If you really think about it, at the end of the day, it looks and feels a lot more like automobile insurance. And even to think of that, right? And I know this is funny with employers. I sometimes use this with them. Employers look at it and say, well, I've got to have every hospital. And I say, well, you don't expect that of your car insurance company. What they're basically going to say is, here's 3 auto shops for you to choose from. Beyond that, it's on you. We're going to pay you a check. There's no guarantees. It's on you after that. But if it's these 3, now it's guaranteed. Again, there's something preferential about it. We're working with them. And I think that's this idea of where, healthcare is community-based. DPC is community-based. So the two can come together, but clearly they have to figure out how to operate in kind of a different revenue world, maybe a fee model. But ultimately, once we do that, I think we can come up with something that really is quite fantastic.
Oh my gosh. So we'll embarrass Dr. Gold. He had an emergency come up. And so yeah, he wants to talk later tonight. We'll see 7 p.m. Eastern. He's up. That will be a fun conversation. So I told him I'll ask you. Oh my heck, that's going to be a robust discussion.
Right.
We'll have to see.
I know I'm out on that one. Well, I have a date with my daughter. I bought her a motorcycle and we're going to go pick it up. So.
Oh, fun.
Of course,
Well,
gotta go see if I can, take her and maybe get her to use healthcare someday, or hopefully not.
So she's gonna have a bike, and because you drive, and I forget what kind of motorcycle do you drive?
I have a few. I have a road bike and a dirt bike, and then I just got her first dirt bike.
Oh, okay. So I love dirt bikes. I grew up on a dirt bike, but so Arnold Guthrie, right?
Uh-huh.
I don't want a pickle. Don't want a pickle. I just want to ride my motorcycle.
That's right.
Yeah. I digress. So I don't know. Here's another question I sometimes get. What about if you have a member who is already seeing a doctor that they love, and maybe their employer's looking at DPC? What happens then?
Yeah, no. And I think this is where, again, I think there's a lot of options, but from an employer's perspective, and I believe many consumers that have primarily been in the commercial market space, right? Those of us that, usually work for employers, we tend to look at it very myopically and believe that fee for service is really the only way that it works in the commercial space, right? That it's, I'm going to go in, there's going to be a bill for that. I may or may not have some cost share or pay the whole bill. But at the end of the day, it's going to get billed to my insurance and it's going to get applied to some, right, whatever cost share I have. And the reality is, if you swing around on the other side and you look at it from a provider's perspective, this is only one of maybe a dozen ways that many different types of providers get reimbursed. And so I think that that's the first recognition, is that employers probably need to begin to create avenues so that there's more than one lane. There could be a lane that works more like a traditional system where a member may have the ability to go to a whole panel of physicians, or the one that they've always loved, which is in a network per se. But they're always going to have some sort of a copay, right? So that there's not a level of overutilization, but there's also not this kind of this hope that there's this great engagement necessarily. If it is a great relationship and it exists, wonderful. But at the end of the day, the insurance product isn't necessarily what's creating that pathway. Versus then another pathway where, let's say, a member could nominate a provider and say, where the employer offers saying, we're going to pay X, right? And this will just be guaranteed. You'll get paid every month. We just need you to take care of the patient now. No billings after this, maybe just track the records and chart it. But beyond that, we really just want you to focus on a better relationship and making this person well. And I think in that type of a model, you've offered it for both, right? The challenge with it is that, again, we're so anchored back to the insurance systems. I have seen no evidence that traditional insurance or network-based programs are moving this direction to where they're going to create multiple pathways for access. So at that point, it really does put it back on an employer to become unbundled, to become independent, right? Where you're self-funded and saying, I'm going to choose my administrator. I'm going to choose how we're going to operate our health plan. And although that can sound scary and very complex, and in some situations, depending on your creativity, it can be, I also believe that it can be extremely liberating and rewarding, to where I would say that probably 95 out of 100 employers that would move to self-funding would profess that it was one of the best decisions that they've ever made. The other 5 probably have 1 or 2 that have gone back for, usually cash flow or other financial motives. And sometimes it is just simple administration. So, I think the reality is most people do determine that the effort is worth it at the end of the day, because it gives them the freedom to imagine. And where we've always said in the past, you can't do that, or why doesn't the insurance system allow me to do that? You now are running your own health plan and saying, how do we do that, right? And that's a very different question from an employer's perspective, especially when you're truly advocating on behalf of your employees and wanting them to have a better interaction with the healthcare community.
Right. And then it seems to me you get in this situation where, because I don't know an individual, an employer, or a provider who wouldn't like to see more emphasis, tangible emphasis, I would say, on wellness, right? Because I think most of us will agree that we don't invest in wellness on a broad scale. We pay for sickness. That's what we reward. That's what's paid for. Versus a model like this, where you can really forward-thinkingly, in a forward-thinking manner, embrace and put some teeth in what it means to truly garner and build wellness in a population, which is powerful. I mean, a lot of people talk the talk. We want to do it. We say we do, but yeah,
It's really interesting. I have a client that is extremely passionate about their workforce and has been working with us for about 6 years now. And it was probably, and I think it was in year 3, it was 2 or 3, we started a fairly robust wellness and engagement program. And I candidly went along with it begrudgingly. I somewhat told the employer that I wasn't a huge fan because I always felt that the engagement rates were so low. And that for the effort that you go through, and that even once you have some level of data, it's not always actionable data, it's historical, and so you really have to almost really commit to this from a long-term standpoint, and that don't look back at your premiums. And what was so interesting was probably 3 to 4 months into it, I can remember them calling up and saying, "How did you know?" And I just said, "Well, it's human nature." I go, it's just human nature. I go, as leaders of an organization and of a health plan, you're excited. You're taking this on as a challenge. You're doing something to them. That's how they view it. And I go, they're not really engaging in this from a health-minded standpoint, other than the people that would be doing it anyway. So you really don't get a marked change in results, but you feel like you put all this effort in, and then only to find out 35% of our people participated, even though you put out all of those incentives. So it was interesting. We kind of did a base calculation on what that investment was. And the employer then came into the next year and said, we were fully committed to this, and we are still, but we've also decided that we wanted to give something more meaningful back to our employees. We want to reduce the deductible by $500 and go down another $1,000 on the out of pocket. So over a 3-4 year period, this now represented a $1,500 reduction in the deductible and $2,000 in the out of pocket maximum. And you should have seen the employees' reaction at open enrollment. They were so
it was
appreciative.
meaningful for the member.
They didn't have to do anything. Yeah. And we opened up a couple of new plan design options based on some feedback. And the employers, it was kind of interesting the way they came back and said afterwards, they're like, we always feel like we have to make them do something. But the reality is, if we'll give them the tools, they'll probably go do something with it. And if not, well, they probably weren't going to anyway. And we're just going to have to kind of be okay with that. But nonetheless, we've got to remove the barriers. And they got it, right? There was kind of that moment of where they recognized they needed to invest their dollars, not just because of what they thought was best, but rather how were they really going to get the results? And ultimately it was by listening to the end user. So kind of an interesting case study around that. But I do believe that then once you get that buy-in from your population, and then you also get that buy-in from the provider community, like we do in our direct partnerships, we've actually seen what starts to happen with the numbers over several years. And you can truly see that there are changes in behaviors, there's pattern adjustments, and you can start to then look at the correlations of your outcomes, your pricing, and there is a difference, right? So the reality is you can get people to behave differently, but I think it's based much more on carrot and kind of nurturing and working with them, as opposed to kind of making them go and do something. Even if there's incentives placed in there, you almost have to ask them to do it. It's a little bit different.
Well, and it has to be meaningful. We go through that too. People always ask, like with our Health Reach 360 program, how do you get an engagement rate of 80 to 90%? People aren't engaged. Well, most programs, like you mentioned, they don't have any meaning to the end user, the member, right? But nobody wants to be sick. Nobody wants to be fat. Nobody wants to be broke. Nobody wants to not have energy at the end of the day for their family, right? People will get healthy for a minute for a gift card, but that's not where that meaning comes in.
Right.
So
absolutely,
those kind of meaningful carrots, and then providing that value, that's really where you're going to find the behavior change that drives the ROI. Right?
Absolutely. It does. It truly does. Well, Kimberly, I told you I was going to ask you a question, and I have about 4 minutes left here. So I want to make sure we finish with you. You are always very busy. I'm a big fan of yours as well. I love kind of just watching all the folks that you interact with. I'll say the just positive attitude that you shower across our industry. It's very appreciative, right? Because I think a lot of people, although they're influential, sometimes they do it with a stick. And you definitely have a voice, but it's very nurturing and accommodating and inviting. And so I appreciate that. You meet some amazing people, I'm sure, and you ask great questions. I know you have a true passion for this. What's that thing you've come across that has you probably the most excited? That you look at and you go, I think this is different. This is something everybody should be aware of.
Oh, dude, buckle up. You better put on your helmet. Seriously and truly, like the series we did on the Mavericks, where you were featured as a Maverick. I would say, very early on in my career as a nurse, I found that healthcare, while most of us come into healthcare because we care, it kind of gets beaten out of you because it's really not about healthcare. It's about the dollar bill. And I'm all for the dollar bill. I love making money. It's one of my favorite hobbies, right? Who doesn't? If you're going to do anything of any significance, you got to have some basis of stability. And, profit is a part of that. However, I will say why I'm so excited about our industry is because of folks like you and Dr. Gold and the Bob and Craig Clemente, where I work with specialty care management, being able to partner up. And sometimes, people kind of think I have been accused of being a Pollyanna, but it's real. I really, truly do believe that when people do the right things for the right reasons in the right way, it's going to have an outcome. And it's going to have an outcome that's going to feel good at the end of the day, at the end of the game, right? And maybe that's a little bit where my clinical background comes in, because I've held a lot of hands as people go out of the world. And that really helps. Matter of fact, Ben Wenfield, if you know Rover Analytics, he was talking something about that today, about perspective. And I think, coming from a framework where the end in mind is, I think that's a huge driver. And there's so many people in our industry that are really trying to poke the bear. I'm not really an original person. I'm real. That's who I am. I'm not phony, trying to put on a show, but I don't have any original ideas that I bring up. But I love all the original ideas that are out there of people really and truly creating meaningful impact. And that to me has me excited. And at the end of it was interesting. I was thinking about that the last night as we watched a classic good guy versus bad guy scenario show. I love those. But, the bad guys don't stay in the game. The bad guys never win because the good guys dig in and they roll up their sleeves and they go to work. And I'm not saying that there are good guys and bad guys, but there are, right? But however, my focus in that is saying that people who really are driven by a desire to do something significant in terms of benefiting other people, like you, that's going to be the driver. That's really going to truly be what saves our industry. I would much rather see those of us who work in healthcare, do that than somebody outside of healthcare. I don't think we're going to like what they're going to turn it into. And I think we have all we need right here to make it a better place in terms of an industry.
Absolutely right. Well, we are fortunate, and I don't know who would call you a Pollyanna. I do not believe that at all. I'm a peppy and positive as well. So anybody that calls you that has to call me that as well.
Oh, get your pinafore.
I'll take that all day. I love that one. So, well, Kimberly, this has been great. As always, I truly appreciate my time with you.
Oh, right back at you, Doug.